Morgan, Catherine, can you guys hear me?
Yeah, we can hear you.
Okay. Feeling better, Catherine, or still yuck?
Oh, well, my eye's swollen. I did have a negative COVID test, but we'll see how it goes.
Okay, there's a silver lining there.
Yeah.
Oh, okay. You can misspell it, that's okay. The quiz is trying to Jesus condemned the town of Chorizo. Can you spell it? You spell it right? It's the same right. Well, I don't Perfect. That's any other guess is gonna be. Can we go over the like interviewing a pharmacist, like what you need to do with that?
Sure. So Haley asked if I'd say something about interview with a pharmacist. So you find your pharmacist, you interview them, and then you put together a presentation. You can videotape yourself. Most students use their phones, or their roommate uses their phone or something like that. And then I still haven't done the assignment where you submit it. I need to do that. Then you submit the video, and then the questions that are on the syllabus, you fill those out and you hand that in as a Word document. And so half your grade is the presentation, which really needs to be under 3 minutes. And then the written document and the grading rubric is on the syllabus.
What is that?
That is due essentially finals week. So, and Catherine, Morgan, I'll talk to you guys about the quiz once we're done with today's class, okay?
Okay.
All right, we ended up last time with our discussion of headache treatments. All right, we took a look at tension headaches. We took a look at migraines. We're still looking at the medication used to treat migraine headaches. Very often for tension headaches, there are relaxation techniques you can use. There are other sorts of non-pharmaceutical interventions you can use. So as we said, the triptans are kind of the go-to drug. Triptans can arrest an already existing migraine. That's a big strength of the triptans. They're not a prophylactic medication per se. They're meant to treat a migraine that's in full bloom, so to speak. So these are serotonin receptor agonists. They bind those receptors and they deal with this massive vasodilation that occurs within the skull, and they decrease that large amount of vasodilation that can put pressure on the meninges and cause pain. And sumatriptan comes in this newfangled intranasal form. There's a subcutaneous form as well. There is a dermal patch now of, pretty sure it's sumatriptan. With patches, you must remember, you never put a heating pad over a patch. That will cause the patch to dump all its medicine and you'll get massive drug toxicities. Secondly, you want to make sure that the patch is applied to a relatively hairless spot. If you have some bloke who has, he's like a bear, they've got hair everywhere, then tell him to shave. And if you're training him how to put a patch on, which you should train them how to put a patch on because it's not obvious how to put a patch on. People can read instructions and make lots of hay of them. So demonstrate to them how to put a patch on. Always wash your hands and don gloves when you put patches on. You take the patch and you write the date and the time on the patch. Date it, put the time on. Make sure the area to which you're applying the patch is clean and dry. That's very important. When you apply the patch, you make sure that the patient is educated as to how long the patch should be on. Many patches you can take showers with them on, but there are just things you don't do. When you're disposing of a patch, you never take the patch and put it in the trash can, because little kids think those patches are really cool and they'll pick up the patch and they'll lick it. And, kids, Steph, where do kids put things? First place, that's the universal probe right there. So they're gonna put it in their mouth, and if there's drug left on there, which there usually is, they're gonna ingest that drug and they're gonna get way more than they should get. So patches, you fold them in half and flush them down the toilet. That's what you do with a patch, always. Never throw a patch in the rubbish bin, never. Flush it. All right, so we talked a bit about the different types of side effects for the triptans with the sub-Q sumatriptan. You can get usually some sort of issue at the injection site when you inject it. Tends to burn when it goes in. That usually doesn't last very long. Intranasal forms can cause an unpleasant aftertaste, and they can actually they can change your sense of taste a little bit. Most people have said it's not that big an issue, but some people reported changes in their taste sensation. The other issues usually have to do with raised blood pressure, fatigue, drowsiness, dizziness, flushing, tingling. And then some people have sleepiness, weakness. It's hard to say if that's part of the drug or part of the migraine, because migraines tend to do that to you anyway. So that one, there's still, it's hard to say. Sumatriptan is contraindicated in people with severe liver disease. So is naratriptan. Naratriptan is also contraindicated in patients with severe renal impairment. You don't use triptans if a patient has angina pectoris, or if they've had a heart attack, or if they have certain types of cardiac arrhythmias. The triptans can make those worse. If they've had a stroke, nope. Seizure, triptans can make seizure disorders worse. Also contraindicated in people with certain types of uncontrolled hypertension, bowel disease, ischemic bowel disease, peripheral vascular disease because of the vasoconstriction they cause. And in people with diabetes, if they're diabetics can use triptans, but if they're at risk for vascular disease, the triptans can accelerate the progression of vascular disease. So these drugs, they work really well, but they have some caveats. Caveat, by the way, is Latin for beware. Things of which you should beware. If you take 2 doses of triptan, you should wait within 24 hours, then take another dose. Don't take another dose right after that. Don't use it with an ergot derivative, which are also used for migraines. The effects of triptans with ergots are additive, and they'll raise blood pressure in an additive manner. And don't use them with monoamine oxidase inhibitors because they can cause a serotonin effect in that case. So you want to be aware that if you use triptans within 2 weeks of something like a monoamine oxidase inhibitor, that increases the concentration of the triptan. That can increase the risk of serotonin syndrome. So those are 2 agents that probably just shouldn't be mixed. Most of the triptans, well, at least these 3 here, are substrates of cytochrome P453A4. And so you should not use those particular triptans in combination with strong 3A4 inhibitors. And at least with elatriptan, you should wait 3 days before you use a drug that's a strong 3A4 inhibitor. And if you combine these with SSRIs, at least in clinical trials, serotonin syndrome has emerged. So many neurologists I've talked to have said, nah, won't go there. Others have said, depends on the dose, depends on the triptan, depends on the SSRI, depends on the dose, blah, 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 so on and so forth. A study in Norway failed to show any link between triptans and birth defects. So they seem to be safe during pregnancy. Also safe during breastfeeding. They're just not excreted at very high levels in breast milk. So calcitonin gene peptide, calcitonin related gene peptide is a rather potent endogenous vasodilator, and it also greatly enhances pain signals. It's known to increase during migraine attacks, and if you administer CGRP intravenously, it can precipitate a migraine attack by itself. So this particular small peptide seems to play a pretty potent role in migraine pathophysiology. Therefore, it's a target for pharmacological intervention. There are two small molecule CGRP receptor antagonists. I don't seem to have listed those. Okay, I'll list those. These end with GEPANT, GEPANT, GEPANT. So there's ramigapant and ubrogapant. When you see that ending, that tells you that these are CGRP receptor antagonists. Both of these drugs are FDA approved for acute treatment of migraines in adults. They reduce migraine pain within about 60 minutes. So they don't work quite as fast as the triptans. Ramigapant has a longer half-life than ubrogapant. So ramigapant has a half-life of about 11 hours. Ubrogapant has a half-life of about 5 to 7 hours. Unfortunately, there aren't any head-to-head tests of these drugs versus triptans. Based on the relief patients get, they don't seem to be as effective as triptans, but there are no head-to-head comparisons yet. So these drugs are pretty well tolerated. Nausea and sleepiness occurred in less than 5% of patients. They don't have vasoconstrictive effects, so they're not associated with rises in blood pressure. They've also not been associated with rebound headaches. Some migraine medications will cause rebound headaches. In fact, if you get a patient who comes in and they're just really chucking the acetaminophen or ibuprofen or something, and then they come in and have a really bad headache despite they've been taking medication really consistently, it's very possible they could be having a rebound headache. Rebound headaches can be of the tension type or even of the migraine type. Both of these particular drugs are metabolized by cytochrome P453A4. So if you use other drugs that are strong inducers or inhibitors of 3A4, they can raise or lower the dose of these particular drugs. There are some other drugs that selectively bind to this particular serotonin receptor, H5T1F. H5T1F, why is it so special? It's expressed on trigeminal neurons, and the trigeminal nerve seems to play a really important role in the initiation of migraines. So this particular drug, laminitan binds to that receptor and activates it. In clinical trials, you can see you have better relief than you do with placebo. 30% to me is not great, but that was enough to convince the FDA to market it because it's significantly higher than what you get over placebo. Again, no trials comparing this with the other drugs head to head. You can get some CNS related adverse effects, dizziness, tingliness, paresthesia, sedation, vertigo, ataxia, cognitive changes, confusion, that sort of thing. Patients are best served probably taking this drug at night for that reason. Also, if they take it, they shouldn't drive or operate heavy machinery or do something like that. Some GI issues have been reported, but they're not very common. 0.2% of people have hypersensitivity reactions. And also things like increases of blood pressure, decreases in heart rate have been reported. The drug doesn't, as far as can be told, have vasoconstrictive effects. But this drug, as you can see, does cause some side effects. Now, the advantage of this drug is that this drug can be used in people with vascular disorders. It's very safe in people with vascular disorders. The FDA insisted on a black box warning for this drug against driving or operating heavy machinery at least 8 hours after taking the drug. So it's a Schedule 5 controlled substance. If you take lasmiditan with alcohol or other things that suppress the CNS, the effects will be additive. And you get serotonin syndrome if you take it with serotonergic medications. Not known if you can use this with a triptan. That's not known. And it should be used with caution in folks who are taking other heart rate lowering medications like beta blockers or something like that. So ergots are derivatives of compounds that are made by fungi. So during the Middle Ages, there were times when the wheat was stored in barns and it got wet. And when wheat gets wet, it can mold. And one of the molds that can infest wheat is a fungus called claviceps. Claviceps purpura causes ergot of wheat. And when people ate the wheat, they had some really nice trips. They saw, horses coming out of lakes and stuff like that. And some of the visions that you see in literature from the Middle Ages could very well be trips caused by claviceps purpura. Well, claviceps purpura makes these compounds that are called ergotamine. Turns out that these can be used as treatments for migraine headaches at controlled doses. The advantage of these drugs is that they're very inexpensive. So this particular one, ergotamine tartrate, is combined with caffeine, and it's available as Cafragot. It's also available as a suppository, and it is used to treat migraines. There is an injectable version called dihydroergotamine, and it's used in patients who don't respond to triptans. There's also a dihydroergotamine nasal spray that can be used. So these drugs are weaker vasoconstrictors than our triptans, but nausea and vomiting are pretty common with these drugs. Now, turns out you can pre-treat the patient with an antiemetic. So you can use metoclopramide, you can use ondansetron. If you guys have worked in hospitals, you've heard the name Zofran. Zofran is ondansetron. And that will reduce the nausea and vomiting. Serious side effects have been reported. They're rare. But the serious side effects include occlusion of certain vascular trees in the body, causing organ ischemia and gangrene. Those are usually associated with overdosage. These drugs can be hard on the liver, so you want to be careful if the patient has some sort of liver malfunction. And you don't use them in people with either arterial disease or uncontrolled hypertension. They are not safe during pregnancy and lactation. The ergots reduce placental circulation during pregnancy. And the use of ergots are also excreted into breast milk, and they are contraindicated both pregnancy and lactation. If you combine them with triptans, beta blockers, dopamine, nicotine, the effects of ergots are potentiated. Ergots are dependent on cytochrome P53A4. So if you use strong inhibitors, the ergot concentration goes up, and then you can start to get organ ischemia. So you don't combine ergots with 3A4 inhibitors. Never, 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 never. If you used a triptan and it doesn't work, you have to wait at least 24 hours before you take an ergot. Let's look at preventative medications. These are meant to prevent the onset of migraines. The other drugs we talked about treat migraines once you get them. Beta blockers are pretty commonly used. Propranolol is probably the most heavily used. Many people who use propranolol say that it works. Other beta blockers have been used. These others, atenolol, metoprolol, bisoprolol, those are better for people with asthma because they're cardioselective. These tend to work pretty well. They can cause tachycardia. They can cause some exercise intolerance. You tend to get used to that. If somebody with a migraine has comorbid depression, beta blockers can make the depression worse. There are a couple of anti-seizure meds, valproate and topiramate. Topiramate, I believe, is sometimes marketed under the name Topamax. Valproate gets marketed under the name Depakote. Valproate is also used to treat, if it sounds familiar, it's used to treat bipolar disorder as well. But these can reduce the frequency of migraines. So these are potential preventatives for migraines. In randomized double-blinded trials, topiramate is as effective as propranolol. We'll look at topiramate when we talk more about anti-seizure meds. A side effect of topiramate is your appetite gets decreased, so the patient loses weight. So if you have a patient who needs to lose weight, topiramate might be a nice way to help them lose some weight. Valproate tends to cause nausea. Nausea is pretty common with valproate. It can cause tremors. It'll cause weight gain, and it causes your hair to thin. And guys, it can cause your hair to just fall out. There are some rare side effects with the liver. They're not very common. These other things, menstrual disturbances, hairiness, lipid abnormalities, those have been reported. POS, what have you, not that common. Topiramate will cause weight loss, taste disruption, albeit at low doses, doesn't tend to do that. Can kind of make your thinking a little foggy, but that's dose dependent. And it can cause some fatigue and paresthesias. Rarely, it tends to increase the risk for narrow angle glaucoma and decrease sweating. Neither topiramate nor valproate are safe during pregnancy. Of the antidepressants, amitriptyline is the only one that is shown to have any effectiveness when it comes to migraine prevention. Nortriptyline, which is better tolerated, has been used off-label. A couple of neurologists I've talked to said, yeah, people use it, but it doesn't work. And you can see in a trial with pediatric patients, amitriptyline really didn't work. So if it works, it really only works in adults. The serotonin norepinephrine reuptake inhibitors, venlafaxine and duloxetine, have been used. Their effectiveness is such that they're not first line. They also have, especially venlafaxine, has a lot of side effects. So these are 6 to 1, half dozen of the other. So these particular drugs are parenteral drugs. They're antibodies against the calcitonin gene-related peptide. These are long-acting. You take these, you get these at the doctor's office. Some of these actually come as pens and injector pens. You can inject yourself. You don't have to go into the doctor's office to get them. So irenumab is one of the older ones. And irenumab comes in an auto injector, and you inject yourself once a month with that drug. And these drugs are pretty effective. Pretty effective. The others, you'll notice they end in nizumab. So fremanezumab, galcanezumab, eptinezumab. Those also come in syringes and auto injectors. And those are also taken about once a month as well. These can cause some injection site issues. Hypersensitivities have been reported. Constipation is a relatively common side effect that's reported. About 15–20% of people report it. So what are you going to advise your patient to increase in their diet? Fiber. Eat that salad. Take that fiber. The other thing to decrease constipation is hydration. Make sure they're hydrating. That will tend to mitigate constipation as well. There's no data on if these drugs are safe during pregnancy. The Erenumab is safe and effective in women with menstrual migraines. So that is the drug of choice in women with menstrual migraines. So, which of these drugs treats an active migraine? Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? You're right, it's C. It's C. Triptans are meant to treat active migraines. They're not meant to be prophylactic drugs. Propranolol, amitriptyline, eptinezumab, those are all prophylactic. Those are meant to prevent migraines. Which migraine medication should not be given to patients with vascular disease? Diclofenac, zolmitriptan, ubrogepant, or lamidatan. Lasmiditan. That one, my tongue trips over that one. Which one should not be given to patients with vascular disease? Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? Well, D is a drug that's for people with vascular disease, so it's not D, and it's not C. Ubrogepant seems to be safe in people with vascular disease. The best answer with that one would be zolmitriptan. That one has a long half-life. Which of the following are potentially severe side effects of ergotamine treatment? Nausea, vomiting, bradycardia, or immediate claudication? Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? Yeah, the answer is D. Claudication means that the vessels have been cinched down and you get pain usually the legs in that case. That is a sign essentially you're getting a severe side effect of ergotamine. Question 4. Which of the following drugs is safe for preventing migraine headaches in pregnant women? Is it galcanezumab, venlafaxine, propranolol, or valproate? Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? You don't give Pro-A during pregnancy. That causes neural tube defects in babies. It's a very teratogenic drug. Never. Propranolol. Propranolol is safe to give during pregnancy. Which medicine is a serotonin receptor agonist? The serotonin receptor agonist. Is it A, sumatriptan? Is it B, tremelimumab? Is it C, romigapant? Or is it D, metoprolol? Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? The answer is A. That's what triptans do. They are serotonin receptor agonists. Tremelimumab is a calcitonin gene-related peptide specific antibody. Romigapant is a small molecule that binds to the calcitonin gene-related peptide receptor and gums it up. And metoprolol is a beta blocker that blocks the beta-1 adrenergic receptor. Questions on the migraine meds? Well, this is a good time to take a break, and then we will talk about medications for Parkinson's disease.
Start reading. Read the number beside you. I remember this last year. I was thinking when we and then I went
Okay, ladies, you guys online, let's talk a bit about the quiz. Morgan, are you going to be on campus this week or no?
I'll be on campus tomorrow and Friday.
So I can give a quiz to Catherine, our secretary, and you can see her and take it. Will that work?
Yes, that'll work.
Okay. Catherine, it kind of depends on how you feel, huh?
Yeah, I'm thinking I'm getting better. I've taken some medicine and it seems to be in the right direction, but
I'll tell
the
you
home
what.
health people just told me see how it goes by Friday. So I'm hoping it'll be okay by,
What if I give Catherine a quiz, and if you can't come in and take it, then we'll make other arrangements. Will that work?
for Morgan or myself.
Catherine.
Oh, yeah, that works for me.
Okay, excellent. Then I will give 2 copies of the quiz to Caitlin Chevalier, our secretary, and I'll tell her you guys are coming. Just stick them in my mailbox when you're done, and that should work just fine.
Okay. So just anytime like this week? You
Yeah.
think? Okay.
Anytime.
And she's just there in the main office in the science building?
Uh-huh. Yep.
Okay. Awesome, thank you.
Okay, guys. Have your resumes. So Parkinson's disease is the result of degeneration of dopaminergic neurons in the substantia nigra, which is in the midbrain. The symptoms of Parkinson's, many of you have probably seen these. I know many of you work as certified nursing assistants. I don't think you can work in a retirement home without at least seeing somebody with Parkinson's. Is there anyone who has not seen Parkinson's? Okay, just a few of you, just a few of you. So most of you have seen it in one form or another. So probably one of the features that you start to see early is the tendency for the gait to consist of, instead of a regular step, the steps are very short. Also, the arm swing is, and it can be restricted to one side. So the gait, the patient will be stooped forward, and the steps will be kind of baby, mother may I, baby steps, and a resting tremor is also pretty common. In fact, that's one of the first things you start to see. The resting tremor is also usually only on one side. And so at rest, there's a tremor. Now, some people can have essential tremors. This is not an essential tremor. Essential tremors tend to run in families. Some of your families, you may have an uncle or a grandpa or somebody who shook. Renee Runyon, who plays piano, she's a piano teacher, her brother and his wife moved to Spring Harbor. He's got essential tremors. It runs permanently in his family. And he was helping somebody with their bow tie at the concert, and he was shaking like a leaf. He was having a lot of trouble with it. So I said, let me do it. And I went and I did it, and I said to myself, that looks a whole lot like essential tremor. And I talking to him on the way home from rehearsal, he said, yeah, I had that essential tremors. So essential tremors will tend to be bilateral. Resting tremors, also essential tremors you shake whether you're doing something or not doing something. Resting tremors, once you start to move, the shaking doesn't go away, but it gets usually less severe. The other feature that you'll start to see is so-called pill rolling. The fingers will tend to do this. Like there's a pill. Pill roll. And then maybe with shake or something like that. So the face, you have this condition called hypomania. You don't tend to show a lot of expression, so the face is just expressionless. You also get rigidity. So the rigidity you get in the elbow, you get if you take the patient and you just have them relax and do this. On a Parkinson patient, when you do this, you have to really push. That's called lead pipe rigidity. And then with the wrist, when you move the wrist, you'll actually go click. That's called cogwheeling. Cogwheeling. Now here's nice and relaxed. That cogwheeling sort of thing, when you do this sort of exam, these sort of things come out really plainly. Then you have the patient walk, and you'll see it. So, what causes this? So, in the midbrain, you have the substantia nigra, and the substantia nigra is connected to the basal ganglia. The neurons in the substantia nigra are dopaminergic. They secrete dopamine. And there are two different pathways by which they're connected to the basal ganglia. One of them is the direct pathway. The direct pathway utilizes the D1 dopamine receptor. The indirect pathway utilizes the dopamine D2 receptor. The direct pathway initiates voluntary movement. It's pro-movement. The indirect pathway tends to inhibit unnecessary, unwanted movement. So if you have a defect in the direct pathway, you will tend to have hypokinesia. In other words, less movement, slow movement. In the indirect pathway, if you have a disruption, you have unwanted movements, you have so-called dyskinesia. Both of those are features of Parkinson's. So it's a movement disorder characterized by resting tremor, difficulty initiating movement, and shuffling gait. Tends to be diagnosed in old age. Prevalence of it in people over 60 is about 1 in 100. So the treatment of Parkinson's revolves around one goal: increase dopamine concentrations in the midbrain. You can increase dopamine concentrations in the midbrain. You can mitigate the movement disorders to some extent. Now you've got a problem. You can feed someone dopamine until the cows, cats, and dogs come home, and it's not going to cross the blood-brain barrier. So you take a preform of dopamine called L-DOPA. L-DOPA is a dopamine precursor. That will cross the blood-brain barrier. There's an enzyme called dopa decarboxylase, ADC. Dopa decarboxylase converts L-DOPA into dopamine. So this is one way to get dopamine into the brain, is to give L-DOPA. L-DOPA. And if you combine levodopa with another drug called carbidopa, carbidopa prevents peripheral dopa decarboxylases from converting L-DOPA into dopamine. That does two things. It means all of your L-DOPA gets into the brain, and because you're not converting it peripherally into dopamine, you decrease the potential side effects of extra dopamine in peripheral circulation. So L-DOPA is given in combination with carbidopa. This combination is called Cinemet. Cinemet, albeit it's been available for so long now that it's in generic. But people will still call it Cinemet because saying L-DOPA, carbidopa, that doesn't really roll off the tongue, does it? It's a lot easier to say Cinemet. So Jennifer, your mom's a nurse. I'll lay you. In fact, I'll lay you when I got my wallet. You say Cinemet, she'll know what that is. You say L-DOPA, carbidopa, unless she does psych medicine, she'll go, oh, not sure on that one. You say Cinemet? Sorry?
Do you want me to? I'll call her.
Hey, Mom, what's Cinemet? So this is usually the starting material for treatment of Parkinson's is Cinemet. Here's the problem with Cinemet. The dopaminergic neurons are going to continue to die. So Cinemet, you'll have to increase the dose, and then there'll come a point where by itself, it's just not going to really work very well. And so now you have to take measures to increase dopamine concentrations inside the brain. So you give Cinemet help. And so what you're going to do with the Parkinson's patient is you're going to layer medications on top of each other. Each of these are meant to increase dopamine levels inside the brain. So during the first 2 or so 5 years of treatment, the Cinemet gives you a good solid 5 to 6 hours of relief of symptoms. But as it progresses, the duration of benefit between each dose decreases. That's called the wearing off effect. And you get fluctuations between mobility and immobility. That's called the on-off effect. And by 5 to 8 years later, most Parkinson's patients experience dyskinesias, motor fluctuations, and then difficulty with balance, gait, speech, swallowing, autonomic, cognitive sleep, psychiatric difficulties, and so on and so forth. Let's talk a bit about formulations of this combination of carbidopa, L-DOPA. So it comes in sustained release tablets. That's usually what you start people with. And intermediate release tablets for, oh, I just need a little to tie me over, essentially. Also comes in an enteral suspension that's easier to swallow than pills if you're having trouble swallowing, which is pretty common in Parkinson's patients. The immediate release form can be crushed and put in a soda. That will usually help rescue these episodes of hypomobility. So levodopa is absorbed in the small intestine, but in patients with advanced Parkinson's, gastric emptying may be delayed, and it can be pretty unpredictable. That can really affect the rate and absorption and the extent of Cinemet absorption. So the solution is there is a jejunal administration of this medication called Duopa. Duopa. And it's given with a percutaneous endoscopic gastrostomy with jejunal tube or PJ2, PEG-J2. That's connected to a portable infusion pump. It infuses the drug directly into the jejunum. These infusion pumps now are small. They're even portable. You can adjust the dose rate with the infusion rate. You can customize it to control symptoms. After the infusion, the patient can usually take a nighttime dose of immediate release if needed, because you don't sleep with that on. There's also an inhaled form called Inbrija. And this is also used for on-off treatment. Again, this is meant to increase availability for patients who are getting that on-off sort of phenomenon. This is meant to give them something to tie them over, and they don't have to swallow anything. Something to keep in mind, because of the tremors and the weakness, some patients may have trouble administering this. So you might need to administer this, or you'll need to train family members to be able to administer this product to the patient. Not hard to do. Carbidopa comes in a single product. What would you use just carbidopa for? Some people have nausea induced by levodopa. Carbidopa alone tends to reduce the nausea caused by levodopa. It's available in a generic. The trade name of it is Lotosin. This drug is not without side effects. So let's go over them. So the first is that they have GI side effects. They're listed here. You can read them. They cause nausea, vomiting. Also tends to cause orthostatic hypotension. That's worse when you start the treatment. Tends to go away. Parkinson's patients are at risk for falls anyway. So you need to train patient to dangle their feet, to get up holding on to something, and then to become erect while holding on to something. Could be a walker, could be a crutch, could be a person, could be, whatever. They should probably use some sort of assistance walking cane or something like that. With chronic therapy, you can become quite sleepy with this drug. You can have pretty vivid dreams, and some patients can hallucinate and have delusions. And confusion and agitation can be a problem. Impulse control can also be an issue. Inhaled levodopa can cause cough and discolored sputum and increased risk of upper respiratory infections. If you suddenly discontinue levodopa, you will tend to have a very severe onset of very bad Parkinsonism. So this drug really should be stepped off. This drug also interacts with foods. So high protein foods can decrease the effectiveness of levodopa absorption because aromatic amino acids compete for transport with levodopa. Don't use it within 2 weeks of using an MAOI. Don't use it with antipsychotics because antipsychotics are dopamine receptor antagonists. These two drugs will argue with each other. That's a good example of a pharmacodynamic interaction. And if you co-administer an antihypertensive with Sinemet, you can increase the risk of orthostatic hypotension and falls. So those are the caveats of levodopa carbidopa combinations. Now, when levodopa carbidopa needs some help, you can add to this drugs that bind the dopamine receptors. So these are dopamine agonists. These drugs are less effective than carbidopa levodopa. They are, however, less likely to cause dyskinesias and fluctuations. They can even be used early on as monotherapy. But typically, most patients, as the disease progresses, will require addition of carbidopa levodopa. In advanced disease, if you use dopamine receptor agonists, you can lower the dosage of levodopa. That can really mitigate side effects pretty nicely. So the dopamine receptor agonists include pramipexole and ropinirole. Ropinirole is used for restless leg syndrome, but it's also used for Parkinson. The dosage is higher when you're using it for Parkinson syndrome. Then it's pretty low dose when you're using it for restless leg syndrome. And then rotigotine, that's available as a transdermal patch that you can see right here. It goes under the trade name of Nupro. Let's look at some prices, shall we? So 30-day supply of the transdermal rotigotine is $700. Pramipexole generic is extremely cheap. Non-supplied generic pramipexole is $12. Very cheap. The extended release is not so cheap, even in the generic. That's $340 per month supply. The immediate release Sinemet month supply is $30. Not bad. When you get to the extended release, it gets more expensive. It's $300 per month. The enteral suspension, month supply of that is $6,000. That's a little steeper. Apomorphine is an injectable dopamine agonist. The injectable is quite convenient for people for whom swallowing pills becomes difficult. Also comes as a sublingual film. Tends to cause some oropharyngeal side effects, so that's probably not as well tolerated. So these can cause peripheral dopaminergic adverse effects, nausea, vomiting, orthostatic hypertension, low extremity edema. You can use this drug called trimethylbenzamide that goes by the trade name Tigan. Tigan reduces nausea caused by this drug. Don't use metoclopramide, Reglan, because that blocks dopamine receptors. You can, however, use trimethylbenzamide for that. Sudden sleep attacks can occur, so can somnolence, sleepiness, and hallucinations. They can cause confusion and psychosis in elderly patients. They should generally not be given to people with dementia. They can make the dementia a lot worse. Impulse control disorders. This includes gambling, hypersexuality, persistent viewing of pornography, uncontrollable spending, excessive computer use. These are all things you see with dopaminergic drugs, especially dopamine agonists. If you want to get the patient off these, you have to step them off these as well. You should do this slowly because you can get particular bad side effects. Anxiety, dysphoria, irritability, fatigue, suicidal ideation, drug cravings, generalized pain, blah, 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 so on and so forth. Reticotine patches can cause application site reactions. Reticotine, too, for some reason, tends to discolor the fingernails. I don't think anybody knows why, but that's been observed with reticotine. Apomorphine sub-Q injections can cause injection site reactions, and oropharyngeal spasms and things like that have been associated with the sublingual films of apomorphine. So don't use these drugs with antipsychotics. If you use them with CNS depressants, that tends to increase the risk of confusion and sleepiness. And serotonin receptor antagonist is contraindicated with apomorphine because they can cause really severe hypotension. Use Tigan. Use Tigan. Don't use Zofran. The next group of drugs are drugs that increase dopamine levels by decreasing the rate at which dopamine is degraded. So the first group are the COMT inhibitors. COMT is catechol O-methyltransferase. Catechol O-methyltransferase. This is an enzyme that degrades dopamine. These particular drugs inhibit this enzyme, thereby increasing dopamine levels in the brain. These drugs will decrease Parkinson disability, but they can also increase dyskinesias. So these drugs are all going to end in Capone. Capone. So these are the mobster drugs. Al Capone. So these drugs, they drive right over and they nail that enzyme. So there's entacapone. It's available both alone. There's also a product called Stalevo that is a fixed dose combination with carbidopa and levodopa. There's opicapone. It seems to be similar in efficacy to entacapone. Opicapone only needs to be dosed once a day. That's kind of convenient. There's talcapone. Talcapone. This is a more effective drug than entacapone, but it's been associated with fatal hepatotoxicity. It's available in the US, but you have to test the liver really rigorously before you can use it. These drugs tend to cause pretty remarkable diarrhea. They also discolor the urine. Opicapone seems to be the best tolerated GI-wise out of these drugs. If you're going to use tolcapone, you have to monitor liver function every 2 to 4 weeks for the first 6 months, and then periodically thereafter. Serious hepatotoxicity has not been reported with the other COMT inhibitors. Consequently, they get used a lot more than tolcapone. They do make the patient sleepier. These drugs will decrease the metabolism of other drugs that are substrates of catechol-O-methyltransferase, like methyldopa and isoproterenol, two drugs that aren't used a great deal. If you use a COMT inhibitor and a non-selective monoamine oxidase inhibitor, you can get catecholamine toxicity. And if you use these drugs with other drugs that suppress the central nervous system, they can cause central nervous system toxicities and depression. Another enzyme that degrades dopamine is monoamine oxidase, but monoamine oxidase comes in a couple of isozymes. There's monoamine oxidase A and monoamine oxidase B. Monoamine oxidase A tends to degrade all the catecholamines, whereas monoamine oxidase B tends to be more specific for dopamine. So these drugs target monoamine oxidase B, so they specifically raise levels of dopamine in the brain without mucking with the other neurotransmitters. So these are used with levodopa-carbidopa combinations. So salicyline, probably the most used out of this group of drugs. This is an irreversible inhibitor, monoamine oxidase. It does get used as a monotherapy in early disease. It can delay initiation of the use of carbidopa-levodopa. And it is combined to levodopa in people with advanced Parkinson's disease. Rasagiline, notice that these drugs end in giline, rasagiline, salicyline. Okay, that's a weird one, but anyway. This drug is about as effective as entacapone. Then there's a newer drug called sulfonamide. This one doesn't seem to cause dyskinesia nearly as often. There have been no head-to-head studies between these, so it's not known if this drug is more effective. It does cause fewer dyskinesias, though. That seems to be pretty clear. Nausea, orthostatic hypotension can occur with these drugs. If you use sulfonamide at doses that are too high, its selectivity for monoamine oxidase B goes away and it starts inhibiting monoamine oxidase A. And now you can get some pretty severe hypertension, excuse me. These drugs can increase the side effects of levodopa. There's no way you want to use these drugs with methylphenidate, amphetamines, any sort of sympathomimetic amines. They're not degraded, so you're going to get severe hypertension. You can get serotonin syndrome if you use these drugs with SNRIs, SSRIs, tricyclic antidepressants, cyclobenzaprine, the muscle relaxant, St. John's wort, certain opioids, blah, 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 so on and so forth. Having said that, the MAOIB inhibitors can be used with SSRIs and SNRIs. There is a risk for serotonin syndrome, but it's low. So they do get used for depression, but it's usually the case that you don't do that with Parkinson's patients. Also, the antibiotic linezolid can cause serotonin syndrome if combined with these drugs. So this particular drug is kind of new. Istradefylline. So this is another levodopa adjuvant treatment. How this drug's work is not clear. It does bind to this adenosine receptor. So it seems to increase output from the basal ganglia, maybe. Hard to say. This drug does not cause the troublesome dyskinesias you see with the other medications. How it compares with other augmenting agents is not clear. Head-to-head studies have not been done. Istradefylline can cause constipation, dizziness, hallucinations, insomnia, and they can increase the risk of the impulse controls caused by other Parkinson's disease drugs. This drug is metabolized by those two cytochrome P450s. If you use inducers of those isozymes with other drugs, then the concentration of istradefylline will tank. This is a really old drug, amantadine. Amantadine used to be given for the flu. All available flu strains are resistant to it. So it's not given for the flu anymore. However, this drug is an NMDA receptor antagonist. NMDA, N-methyl D-aspartate receptor, is the major receptor for glutamate. And glutamate seems to play a role in dyskinesias. So amantadine is used to prevent dyskinesias. and it's used to treat Parkinson's disease tremors. Tremors sometimes can become resistant to dopamine treatment. And so in cases like this, there is a extended release formula of amantadine, Osmolex XR. And this is used essentially for tremors. The immediate release forms cost a lot less, and they've not been compared with each other for efficacy. So this has anticholinergic effects, can cause dry mouth, constipation, urinary retention. Less commonly, nausea, dizziness, myoclonus, where you get the shaking, insomnia, confusion, hallucinations, peripheral edema, this livido reticularis is heat rash. High concentrations can cause psychosis. QT interval prolongation occurs, but that's dose dependent. Sudden withdrawal can be bad. You can read here. So therefore, you should step patients off this drug as well. If you co-administer this drug with anticholinergics, you will exacerbate the anticholinergic effects of those drugs. Don't take alcohol with amantadine. Bad idea. Bad idea. And if you combine amantadine with other drugs that extend the QT interval, it can increase your risk of torsade de pointes. So most neurologists usually will order an EKG before they start someone on amantadine. We're almost done. We'll finish this on Monday, and then we'll get into the anti-seizure medicines. Let me warn you, the anti-seizure medicines are complicated, extremely varied, and there's lots of them. So we'll probably spend all Monday on anti-seizure meds. Okay, ladies, thank you for coming. I will give Caitlin the test, and Catherine in particular, I hope you're feeling better.
Thank you. Yeah, I was sitting here coughing a little bit more. I think that's because I'm laying down now, so it's coming
Okay.
up.
All right. Good night to both of you. Have a great evening.
Have a good